Hello everyone and welcome. I'm Claire Thayer, Vice President Business Development with MCOL, and I'll be your moderator. We're so very glad you can join us. Our webinar today is Integrating Claims Analytics into Provider Directory and Enterprise Analytics, co-sponsored by LexisNexis Risk Solutions. Our speakers today are Zach Henderson, Vice President of Product and Alliances, and Jim Payton, Director, Strategic Solutions Consultant. Zach leads the Product Management, Vertical Market Management, and Strategic Alliances functions. Jim leads the Strategic Solutions Consulting team for the payer, provider, and alliance markets. Before we get started, we do have a couple of housekeeping items. Our speakers will be taking your questions via the chat, and while all questions will be addressed at the end of the presentation, you're more than welcome to send in your questions to our speakers now and at any time throughout the webinar. If you require any other assistance, please feel free to contact the Healthcare Web Summit office at 209-577-4888. Jim, we're now ready for you to begin.
Great. Thank you, Claire. Good afternoon, good day, everyone. This is Jim Payton. Today's topic, integrating claims into Provider Directory and Enterprise Analytics. We're really going to focus on three particular subjects within our agenda, starting with really reviewing the challenge with maintaining provider data accuracy, driven by both technical and operational as well as compliance changes in the marketplace. We'll talk about best practices for managing accurate provider information and directories. And then we'll talk specifically about insights that can be gained from claims data that can drive value to your provider directories and other operational areas of your health system. So the first topic we'll talk about is the challenge with provider data. Why is updating provider directory information so hard? There are really three key challenges that we see today in the marketplace. The first is that provider data systems are vast, dispersed, non-integrated. We've all heard about silos within organizations and the challenges of having everybody with their own copy of a provider database, that information not being shared across the organization, so you don't have consistent updates. You have multiple copies. Who determines who's right with the information that they've maintained? Health system, data management is typically not a core competency for most organizations. They may be lacking systems or infrastructure to do the job. IT departments have many other competing priorities. Budgets are challenging, so that competency generally is not of priority nature. And then regulations are becoming much more strict, adding to the complexity of the environment. It's driving new frequencies of activities to keep information up to date. It's requiring additional data points and really driving a focus on accuracy of the information that you maintain within your provider systems. At LexisNexis, as we've worked with hundreds of clients over the years, we've actually gathered statistics on some of the things that we see from health systems and organizations. This chart really reflects information gathered from over 200 different provider master files that we've received over a 2-year period to show that the kind of accuracy challenges that are out there in the marketplace, driven by those key issues around core competencies with data management, disparate systems, and many entry points of provider information into a health system. We see a lot of duplication, and that's both duplication where it's the same provider at the same location, or the same provider with multiple locations listed in a directory or listed within a provider database multiple times. And that, of course, causes confusion on what's the right record. It provides due to differences in that information, it may not provide you a full picture of that provider if you see them separated into multiple records. We see missing and bad phone numbers almost 24% of the time. That obviously creates challenges in the ability to outreach and connect with providers, to get data updated, to send members or give contact information to members as they want to outreach to providers. And of course, that's also a key element that can be used in matching and linking data. So if the phone number is missing, you're missing that key element. 18% of the time we see bad addresses, on average 18%. That's obviously going to cause challenges and costs in the mail shop with a lot of return mail. Can also create obviously deliverability issues and also sending members to the wrong address, or potentially a member missing the fact that a provider that they may be interested in is actually in their neighborhood, but if the information wasn't there, they didn't see it. We also identify a number of other issues that will help a payer provider be able to update the information they have in their providers. Information around if a provider is sanctioned or restricted from practice, retired or deceased, that type of information should be cleaned out of directories, cleaned out of databases, so that you're dealing with the most current information. You're not sending members to a provider that's no longer practicing or able to practice. And then the last issue on there around is a provider participating in your network or accepting new patients. That's really the inaccuracies in that information is really the driver behind some of the new regulations that have come out. Providing information on providers within directories, that a provider is participating in a network. If a member shows up and finds out that after the fact that provider is no longer accepting new patients, is not part of that network, that causes issues obviously with the member either having to pick up that cost or make a new appointment. So those are some of the key issues we see within health systems. And then of course the rules and regulations that are in the marketplace today are continuing to drive the need for provider accuracy, driving the need for changes in the way data is managed. At both the federal and state level, those rules are dictating that provider directories, the online electronic versions, need to be updated at least monthly. Other information needs to be gathered that maybe wasn't traditionally gathered, things like what groups is a provider affiliated with, languages spoken, what types of training or specialization does that provider have that may be important to that member or to the types of treatment they're seeking. Directories also must note specifically which health plans that provider accepts and whether they're accepting new patients. Rules and regulations are also driving that information needs to be collected proactively. So it's no longer up to the provider necessarily to update the health plan, but the health plans need to reach out and verify that information on some frequency to make sure that that's correct. So being very proactive as opposed to reactive. And then other associations within the healthcare industry are also making suggestions of using data better to be able to reduce these types of problems. For example, the use of claims data, which we'll talk about more within this presentation, doing things like monitoring whether claims have been submitted within recent months. And if you're not seeing claims, then take some action to either remove that provider from your directory or verify directly whether they're still participating in your network. From a federal side, there are really two different drivers of the regulations. One is on the health exchanges, the other is on Medicare Advantage. They have a lot of similarities on the types of rules and regulations. They all have similar frequency requirements for updating at least monthly or every 30 days. They're all requiring information on whether the provider accepts the health plan, specifically accepting new patients under that plan. And then on the Medicare side, there's also the proactive requirement that they're expecting quarterly outreach to the providers to ensure that the information they have is correct and whether they're still participating in that health plan. We also see that many states, all but 12 of the states in the U.S., have some other additional regulations around or driving directory accuracy. Some require proactive outreach, like California has an annual requirement that every year you need to get attestation from a provider that their information is accurate. States are also adding on additional attributes that need to be collected on top of what the federal government programs are requiring. And of course, there's penalties associated that can be very expensive, increase the risk for a health plan. We're already seeing audits by CMS with some of our health plan customers. They're undergoing audits requiring corrections due to issues in their provider directory data that has popped up during those audits. So there's audits occurring now that's really driving the need to make some changes and make sure the information you have out there is accurate. And then, of course, the original reason why provider information is such a challenge is because it continually changes. Really, the challenge behind provider directory is keeping up with those changes because they happen so frequently. What we see is, as we work with hundreds of customers in the health plan space, in the provider space, that 2.4% of provider demographics change every month. Providers are changing their affiliation, adding something to their practice, changing their practice affiliations, and then status changes are at about 5% per year. So all of those things on top of those operational challenges of dealing with provider information coming in from multiple sources, human intervention to manually enter data, the disparate systems really just exacerbate that problem. So as the little chart at the bottom shows, that if you started today with 100% clean provider database, if you didn't keep up with keeping that information up to date, within 18 months, half of that information would be bad based on these statistics. So it requires a process that stays ahead of these changes, that's continually monitoring for changes and addressing them. Just looking at sheer numbers on a weekly basis, that means 33,000 addresses are changing. We see 3,300 providers where their name changes each month. We see 1,715 phone number changes and 1,500 fax number changes every week. And then the status changes and credential changes are also very frequent, with state licenses changing, the status of that license, whether it's expiring, whether that license is being added in a new state or with new credentials under that license, whether a provider's qualified to practice, whether it be sanctions, retirement, and then DEA numbers and other credentialing numbers that are also changing frequently. So while we're giving this presentation, your data is already changing. So it's necessary to keep that information up to date and have processes in place to do that. And the other challenge is really it's a balancing act. Provider directory accuracy and the work that you do there has to be taken into account the other impacts that it may have across your operation. Provider data, of course, is valuable across many parts of a healthcare organization's operations. It's important to member access. So there's a balancing act between making sure the information is accurate and making sure that you're providing enough choices of providers to members. Customer service is going to rely on this information. The better it is, the more efficient customer service can be to direct members to the right locations, to be able to connect the dots between information that might come in on claim disputes with the right provider information. And that information has to be balanced with network adequacy requirements. If you remove providers due to inaccuracy issues or issues within your directory, do you still meet the network adequacy requirements? And all the efforts around keeping that information up to date will impact your medical loss ratio in the sense that it is going to be an administrative expense that needs to be taken into account. So the solutions that you want to look at are ones that are going to minimize risk or look to minimize risk, because 100% perfection is probably unattainable. But if you can take the right steps to be able to minimize your risk and still meet your objectives, that's really the holy grail of where you want to be with your solution. So with the setup of these challenges in the marketplace and the key drivers for maintaining provider data accuracy, I want to turn it over now to Zach Henderson, who will get into some of the best practices for managing and maintaining provider data, utilizing claim information to be able to help as an integral component to maintaining complete and correct provider information.
Thanks, Jim. Thanks. And I appreciate the comments and the framing of the problem. One of the things that struck me was you just referred to the 100%. And as we talk about best practices in provider data, I kind of liken it to the origin of the Internet, where if your website was up 99% of the time, that was great because that level was very much at the forefront way back in the 90s and late 80s. So 2 nines was acceptable. I think in addition to the comments that Jim shared with us, nowadays the provider data accuracy world is more of a 5 or 6 nines situation, 99.9999% accuracy. And a lot of that is driven by the regulations, some of which Jim dove into for us. So of course we're all asking, so what can we do about it? And the evolution from 2 nines to 6 nines has caused us to really look at the problem in very different ways. Part of that would involve additional content sources, additional analytic methodologies, and basically a new way of thinking, because the closer you get to the 100%, the more difficult each incremental step is. It's an exponential problem. And so I'm going to walk through what some of these best practices are. If we look at an example provider record, what we've found is just going after the traditional data sources is typically not adequate, both from a completeness of the record as well as the veracity of the record. So in this case, you have Dr. Harry Johnson, and using the traditional inputs such as phone calls, going to the government websites, whether it be INPES or DEA or the state licensing boards, etc., it's not robust enough to fill out everything one needs and get the address accuracy correct, the plans accepted, etc., etc. So you end up with incomplete records, and also records that sometimes are not even joined correctly. So there's the concept of false positives, which is 2 records that shouldn't have been joined are joined in a database, or false negatives, which is 2 or more records that should have been joined were not. And so that, of course, is not an acceptable situation. So at a very strategic level, part of the approach that we found to be more successful and push towards that 6 nines type approach is adding additional data sets. The topic of the webinar, of course, relates to claims, both medical and prescription, but those transactions that are occurring in our very disparate health system every day give us clues as to what is actually happening, not what was reported on a month and a half ago, or not what was verified in a phone call 4 months ago. And the issue is at that point in time, that one field that was verified by, say, a phone call, that's great. The next day, as Jim accurately pointed out, that information became stale and starts to degrade in quality. And so we have approached the problem from, one, the source level, and expanding our view on what sources are necessary, as well as the analytics on degrading sources over time. So that phone call was great on day 1, on day 90, not so great. And so what you have when you do these things is a result set that is an accurate address, as well as all the addresses for a physician. You have all the plans accepted. You incorporate the sanction data. You correct phone numbers. You achieve completeness with billing information and specialization. It's not just what was reported on the INPES file, which, as we all know, if you're on this call, you probably know that that's not the most accurate source other than for the MPI number. So that's a high-level view of what the result set looks like when you do all 6 of these things correctly. And I'm going to go through each one of them and end with the claims piece because that's one of the more innovative approaches. Some of these other things might be different from what you've seen in the past as well. So we're going to talk about referential data to create that foundation from trusted sources of truth and how and when you use that data. We're going to talk about business rules, like I was referring to with the degradation of certain attributes over time. Provider portal data, where we, for instance, have established a provider portal where physicians can come and input and correct their content, so more of a contributory approach. Of course, there's auditing. We're going to talk about the best practices there, as well as multi-channel outreach and this concept of data stewardship. I think when you consider the challenge of taking these thousands of disparate sources and bringing them together, it's partially a sourcing challenge, partially an analytics challenge, and partially there's a lot of SMEs, subject matter experts involved, who do targeted outreach and then make very crucial decisions because everything cannot be automated 100%. And the final piece is transaction data. So even broader than just claims a bill, but there's many transactions going on in our U.S. healthcare system. How do we leverage those to give us clues into what might be changing, give us new content that we didn't have before, and then bring that together? So as an example, our provider MasterFile leverages 2,000 different sources, from their state boards to proprietary sources to multiple claim streams, providers, etc. And it's all coming together to continuously update this record of a practitioner. One of the challenges in doing this, and what I was referring to earlier, is you're bringing together those disparate sources of information, and yet you have to match them correctly. You have to tie them together so that this Dr. Smith receives all the appropriate attributes that you're ascribing to him, and you don't confuse that Dr. Smith with the other Dr. Smith that might be in the same town. That's easier said than done, and it's not just using one identifier to do that. What we've seen is, because at LexisNexis we have not only the provider's professional identities, but we also have their personal identities as people from our identity management business. We're able to look at the physician as a holistic entity, not just their professional life again, but their personal elements as well. And what that allows us to do is bring together those multiple data sources and match them accurately. So what you will see are less false positives, where you're inappropriately combining records, and less false negatives, where you don't combine the record you should have. And the reason typically in most data management scenarios is because you fail to see the link, either a direct link, this MPI and this MPI match, therefore it's the same record, or a algorithmic link, where you use deterministic and probabilistic matching to bring together these two records that might not have an obvious connection. It might be Dr. J. Smith and John Q. Smith, but you know, given 15 other attributes, that that actually is the same record. So that's the sophisticated algorithms that are at play here, and frankly, the only way to do that is to build up that expertise over time, because off-the-shelf MDM, Master Data Management software, can get you part of the way there, but that element of SME, subject matter expertise, has to be built into your algorithms, your analytics, in order to make those matches. And the result is you have less records hitting the floor, the cutting room floor, so to speak. So going back to the beginning when I was speaking about data sources, here are some of the example data sources that many of us use. So the proprietary or the state license boards for all different types of practitioners, not just doctors, but all types of practitioners. The DEA, both federal and state, federal sanctions, exclusions, MPIs, of course, they're sourced from MPES, private IDN and GPO feeds, integrated delivery networks, which are your health systems. But then our approach, and we'll get into this a little more on subsequent slides, but it's to bring together contributory data from the clients that we work with, whether those clients are payers or providers. And the reason why we do this is that contributory nature provides additional insight, not just missing content, but additional insight into which address is actually correct. And if you have the additional sources, you can then verify that. The medical claims activity, I mentioned that. We, as an example, have over 70% of all U.S. medical claims activity. That gives us a lot of clues into creating a better provider record, because the provider is either committing massive fraud or they're actually billing out of that location. And sometimes fraud happens, but when you're looking at the aggregate approach of U.S. healthcare, it can be a very good guiding light there for you. So in addition to having that base master file that we leverage, we also leverage multi-channel outreach. And when I say multi-channel, I mean email, phone, fax, et cetera, et cetera. It's important, and believe it or not, physicians still are quite responsive to fax, and that's primarily driven by the pharmacy dynamic they have where they get patient fax backs for verifying scripts that the pharmacy is seeing. So there's this concept of a HIPAA-compliant verified fax number, and that fax number is used very frequently. So physicians still use a lot of the old school black and white fax, and that is part of a good strategy to reach out to them. It might not be a sexy, so to speak, approach, but it is effective, as well as your traditional data stewards reaching out via the phone. Email is more and more prevalent. I think the key to getting this correct, though, is not just to call everybody, because there's about 8.5 million providers in the U.S. Everybody focuses on the doctors and then even more broadly the prescribers, but there's far more practitioners that are very important to having in your accurate provider directory that are not prescribers, that their information is much more difficult to achieve. And so it's almost impossible to call every single one of these 8.5 million people every single day or even once a month. It would not be a cost-effective approach. So you have to use targeted inquiries for your calling patterns, and I'll get into that a little later as well. So we talk about a contributory model throughout all of LexisNexis, not just in the healthcare division, but more broadly. So for instance, in our insurance business, this is auto insurance I'm speaking of right now, all the different auto insurers contribute to claims from all of their actions with drivers. And we aggregate those so that then when you go on to Geico or what have you to price a new policy, we're helping to assess that risk based on all those contributed claims. So it's a consortium. You move that same concept into healthcare, and what we've created is across payers and providers are not just, say, health systems or doctors' offices, but also pharmacies. They're a provider of prescription medication. We've created this industry-wide consortium where the consumers of the content are also contributing to it. And that's very important for getting additional hits, additional triggers. Going back to the slide prior, I was talking about targeted outreach. Well, if 4 of my local pharmacies and the doctor's office and the ambulatory surgery center all told me that this physician has moved, then I have a very good trigger to do a targeted outreach versus just calling all 8.5 million people every day. And so what this does is it, one, helps you focus your spend on these multi-channel outreach, but two, it reduces the latency at which you can pick up changes. A doctor's address move may not show up for 3 or 4 cycles of the state license file. It actually might not show up for even longer. It might never show up in the INPEDS file, et cetera, et cetera. And the reason why is there's not this necessary requirement to update those particular sources. So using transactional data in this way and this consortium approach, we're able to trigger targeted outreach and then provide a better quality content because we verified it and we knew where to look. So I like to describe it as very similar to what they have out in the Pacific Ocean for tsunamis, where they have all those buoys throughout, because you can't monitor the huge Pacific Ocean, but with those buoys, they will send out signals when they see very large wave changes underneath the surface, and they will trigger an alert that can then be investigated, and so the researchers know exactly where to look. It's the same idea here, and we use a lot of this transaction data, both prescription and medical claims, to cue those triggers. We're also leveraging, and I think it's part of the best practice, a portal designed for providers so that they can, they or their office administrators, importantly, because doctors don't want to have to individually comply with all these regulations, but they can reduce their administration time and still be compliant by leveraging a portal. And so in this context, they're attesting to various pieces of information that are required. They're accessing a system where things are pre-filled for them, and they're more just adjusting it. But the point is we're reaching the practitioner in this case of an outreach via the communication mechanism that they want. So whether it's the portal, whether it's their fax machine, whether it's an email, etc., there's these multiple connection points, and as anyone who understands multi-channel marketing, you have to reach your customer or your stakeholder on their terms. I personally don't do a lot over the phone. I try to do as much as I can through text and email just to be more efficient. So someone calling me probably wouldn't be as effective. And in the same way here, we're able to leverage the portal as a mechanism to reach the practitioner. And we've touched on it a little bit already, but let's take a deeper dive into the claims data. So being able to leverage a daily transactional data stream, and the key is the transaction. Whether it's a claim or not is irrelevant. The important point is a transaction occurred with a bunch of information that is required by law to be on it, and how do you obtain that? How do you analyze it? How do you normalize it and dedupe it? How do you count it and do analytics on it? So what we're talking about is sourcing a very large amount of data, much more voluminous in volume than or in size than your provider directory itself, because that's more attribute and description data. The claims data is 30, 40, 50x the size. So you also have to have the IT capacity, but it is a best practice because it's the way to queue those low latency updates that are occurring out in the system. We're going to talk a little bit about how it helps you build accurate affiliations, how you can find new locations, changes in the provider directory, et cetera, et cetera. But a very important piece. The only thing I'll say on the downside about claims data is it is based on the billing practices of the provider, so you have to have a knowledge of what is appropriate content to use. So again, back to that subject matter expertise. So at a high level, claims can be sourced from three different categories: the provider, the clearinghouse, or the payer. And as I like to characterize it, that's who created the claim, either the hospital or the pharmacy or the long-term care center, the doctor's office, who moved the claim, whether it was the 837 submitted claim or the 835 remitted. Sorry about the typo. But who's that intermediary that moved the claim? And there are many intermediaries, not just clearinghouses, but we'll bucket them together for this discussion. And then finally, the payer, who paid the claim. And then the process goes, of course, back to the provider for the money to exchange hands. And so what's important about this is, depending on where you source claims from, the claim itself and the characteristic of those data vary greatly. So for instance, a payer will have a very solid view longitudinally or over time of a patient. And that's because the payer typically pays for all of the fee-for-service interactions for each of their members, their patients. However, the payer only covers their members. They don't cover across the United States. A clearinghouse, to contrast that, covers every payer. However, if you have 10 interactions as a patient with different healthcare providers, any one clearinghouse might only see 5 of those. So you've lost this concept of longitudinality with clearinghouse claims. Yes, individually they are the same claims, because that same claim existed at the provider, at the clearinghouse, at the payer, as depicted here. However, the source in which you're using it, you have to know what these caveats are, what the acceptable use case is. And those are just 2 examples as it relates to payers and clearinghouses. I could go on for probably 3 hours on the other details there, but it's important as you're using these data, not only understand how big these databases are and challenging they are to work with, but also a lot of these exceptions and rules that you need to leverage and how you pull them in to do analytics to supply your provider directory. So if you look at what you can do, I'll pull in a couple examples and just talk about these. One of the things that claims are great for, because of the very low latency nature, is identifying a new address for a practitioner. The requirement on claims is that the providing physician needs to be on there, the location, the NPI type 2, needs to be on there, and then the remainder of the claim information as far as where was the place of service, the billing amount, etc. That's required by law, but also required to process a claim. So it's typically fairly accurate. So what occurs, though, is there are anomalies in the data that you have to strip out. However, this is one of the first sources where you will see. So a physician is newly minted, they come out and they start writing prescriptions. You're going to see their information very quickly via the transactions because they're actually practicing. So you'll see a medical claim, you'll see a script, and if you see a new address on those things, because each location needs a new DEA pad, a new DEA number and the script pad, or you see it electronically, that will queue a research to verify a new address. So very low latency approach there. And very important for these attestation requirements that are coming out. You can use them to confirm inactive, deceased, or retired physicians. So if you think about it, a physician was practicing and then all of a sudden their volume of claims went from 400 scripts a month to 5, and it's been 5 for the last 2 months. That would be a business rule that would trigger an investigation to confirm what's going on with this doctor. Of course, you're still going to have some refills in there and the smaller amount of activity, but you can use that to trigger and confirm inactive, deceased, or retired physicians, as well as waiting for the Social Security Administration to update the death file. But like I said, the reason you're using the claims data is because of the low latency. Yes, it will eventually show up in the SSA file. However, you will find out about it much quicker if you go this route. Real specialty versus self-reported. This has utility in many different areas, but a reported specialty on any one state board or MPI, MPES file, etc., was at that point in time. And typically there's very loose requirements about the necessity to update those for providers. And of course they're not going to go through every single database that they've ever signed up in to update all this information. It's just not tenable for them. But what I can tell you is that you can use the claims activity to see what how they're actually practicing. So, I know there's a lot of, I've seen this many times. So MD Anderson in Texas, the large cancer center that we all know, I've seen many times where we look in our claims data and we see they're treating thousands of patients and all these medical and radiological oncology diagnoses and procedures, and yet they're listed as an internal medicine doctor. May still be true, however, what they're actually doing in their record of activity is very evident from the claims data. And so what we typically do is we provide the reported specialties, but we also provide a derived specialty that gives insights into, well, how is this physician actually practicing? What does their patient profile look like? And that can be had from the claims data, of course. Even if you don't look at the transaction volumes, even just the existence of their patient population is an important cue into who they really are, not just what they had reported 5 years ago on some file. We can also use it to reactivate a location. Again, important in the attestation game, whereby a physician has attested that this location is no longer viable, or they've moved, or they've expanded, but yet their activity is still being billed out of there. So yes, it might be a billing anomaly, but given some of the requirements that we've seen, I think it'd be a good idea to verify that. That'd be a good thing to call and get some answers on, because not having that location and not knowing what the payer plan profile is for that physician at that location would definitely run afoul of some of the regs. Also, is there a new referral relationship? A lot of what we see in claims data is connectivity. So it's the 6 degrees from Kevin Bacon phenomenon, where everyone's connected in different ways, and that's some of what this visual tries to depict. In the claims data, you can see that Dr. 1 and Dr. 2 share 97 patients. Now, granted, you don't necessarily see the name of the patient, because the claims data we ingest for these purposes is all de-identified at the patient level, but you can see that patient 1, 2, 3, 4, 5, 6 was at Dr. 1, and you can see that same patient number in the claims data at Dr. 2. So you see this concept of patient longitudinality or patient travel, and if it's a onesie-twosie thing, that can be ruled out. But if Dr. 1 and Dr. 2 are sharing 97 patients over the last 3 months, chances are there's a referral relationship going on. And that's important to know as you consider the different places a physician practices. Moving on to new payer plan identified. The day after, a provider will attest to yes, I'm accepting this new payer, this new plan, like Jim said, that data starts to become stale. And with some of the requirements, it might not be until the next month that you have to attest, or the next quarter, or the next 6 months. But wouldn't it be good to be able to provide your clients the most recent update as far as this provider, we've seen a new payer plan combination on the claims data, again, medical or prescription, so that they can have an accurate provider directory. The content is there. It's just the challenge, of course, is just mining it. I don't want to underplay the effort and the expense involved here, but if you're able to do it, you can pick up these clues and lower the latency of your provider directory update process exponentially. You can also see new hospitals and group affiliations because the practitioner might have just received admitting privileges at a hospital, but there's no formal declaration of that. But when you see the activity, you can then affiliate the practitioner at that new location and thus verify what they're doing at that location, what insurances they accept, et cetera, et cetera. So there's, I mean, I could go on, but I just wanted to highlight a few of the important analytics that you talk about them and they're fairly simple. The question is doing them. It's not an easy task, but it is very valuable. And now I'm going to shift gears a little bit and talk about, it's not just about the individual attributes and the accuracy of those. It also goes beyond into measuring and monitoring the adequacy of a provider network. So as payers, we're very challenged with the completeness of the network. That's where a lot of these attestation regulations have come from at a core, is you want to have access. That's one of the triple aims, right? So, and it's one of the things that is in many of the lashback from the state and federal agencies around the attestation requirement is understanding how adequate the provider network is. Not just are you accepting, but also do you have an adequate network? But that requires, unfortunately, analytics such as what I'm going to show you here. One example is the saturation analytic around doctors in my network. Are they saturated with patients from other health plans, i.e., is there enough open space generally? What that takes, though, to do is a large number of databases merged together and then analytics performed on them. So a client provider file, so say a payer's roster, the client member file, the patients, and where they're distributed. The client claims, we typically include our master file of the providers and our all-payer claims database that we've created with those several billion claims. When you put those together, you can start to see the different holes, so to speak, which doctors are overly saturated, which have capacity, et cetera, et cetera. There's a lot of assumptions and analytics that go into that, but it's important to understand the adequacy of the provider network, obviously. And so what that looks like in practice is here, where you basically are comparing a configurable target panel size for each taxonomy, or we'll call it specialty, to estimated panel size based on the claims data. So, you see on the left how you can change it from cardiology to orthopedics or oncology, and then the various hurdle rates about their saturation. And so we typically tune these type of analytics based on these underlying claims data to do stoplighting, for instance. So, the red doctor there in Philadelphia, which is where I'm at, that looks to be Children's Hospital of Philadelphia, I think, maybe a practice nearby there, might be completely saturated with patients related to what a physician can normally do throughout a year or a month-long period based on the evidence of all the claims data we see for them. And it's important that we see not just what claims are going on with that doctor and their patients from one payer. It's important we see across all payers so that we have a complete picture. So that is what you're seeing here is the illustration of all those underlying analytics coming out and then being highlighted. Another example is time and distance analytics. Again, this speaks about network adequacy, but it compares travel time and distance from each practitioner to each of their attributed patients. And of course, you have a lot of assumptions around whether it's rural or urban. In the case of Philadelphia here, do they have to cross the river? Therefore, they need a bridge and the bridge run times. So it's kind of like a macro level Waze, if you're familiar with the app that Google recently purchased that helps you find the best path. But even with the best path for all the patients of a practitioner, is there enough capacity there in the network for that particular provider type? Again, all driven off of this underlying all-payer claims database, and it can help highlight those adequacy problems. There's many other enterprise uses for claims analytics that we've done projects and ongoing work on. So things from understanding place of service and service type distribution for expanding your network. So it goes to the network adequacy issue where if you're completely saturated in a particular specialty or taxonomy, then where would be good targets, which physicians would be good targets to expand your cardiology coverage or your oncology coverage so that you can have that adequate network. Part of how you do that is you understand by doctor, by location, the volume of their patients, the volume of the procedures in that particular service line, but at each location. Now, it's one thing to aggregate a bunch of data, so I'll speak to the projected versus non, and have we call it a convenience sample. But let's say that convenience sample is only 70% of the total. You have to have methodologies and knowledge to be able to project that to full volume so that you can then compare two areas that might have different coverage levels, but be able to compare them appropriately. And so we do a lot of work in there. Again, it's not just sourcing the raw data, which is hard enough as it is, and then ingesting it and managing that big data project. It's also that analytic layer that lays over top of it to help take that data and transform it into claims analytics, not just a bunch of raw claims data. Provider place of service preferences. So where are they spending the majority of their time? If you have good coverage in an area and you see a practitioner is spending 90% of their time at a hospital and hardly any outside of it, you know where they are. You know where your other analytics can queue, so that time and distance analytics, for instance, and you can then start to build out your profile more accurately. Referral patterns are quite key today, both from the provider world and the payer world. So who's providing referrals to whom? And then there's this concept of leakage that a lot of payers and providers are talking about. Are they leaking patients to other networks that they shouldn't be? Of course, the financial analytics around missed discounts and overpayments. And then we actually do a lot of leverage these claims data for identifying fraud, waste, and abuse by seeing which practitioners are related to which other practitioners. So back to the summary, you have this balancing act. Getting an accurate provider directory is about a lot more than having one valid address or having a full fill rate on your address one column. It's about having the complete view of a provider and making sure that each of those attributes is as low latency accurate as possible. And I think what we've gone through today gives you some ideas on strategies that can be done to enhance that and get you closer to that 6 nines. So in conclusion, provider data accuracy is required by many state and federal mandates. And the reason why, other than just, we don't want to fall short on the Affordable Care Act promise, is that for almost every state, Medicaid, their healthcare budget is their #1 budget item. They don't have to fund defense like the feds do. So they very frequently look at cost issues within and clawback opportunities within their states. So that's why you see this proliferation of state-based regulation. And I think your solution on maintaining your provider directory needs to consider the state regs as well as the federal regs, because they will definitely go after people who are not compliant. A multi-pronged approach is the best, we think, and one of those key prongs is the claims data, both medical and prescription, because it's one of the most low latency options that we've found as far as detecting change in the marketplace. And so with that, I will turn it over to the group in the chat room to ask questions. Again, that's in the lower left side, and we'll try to answer a few questions before the end of the session.
Let me just thank Zach. So we have a few questions that have come in. I can take the first question that I see out here. First question is related to, does our solution cover CMS and state level requirements, and do we handle facilities in that process? The answer is yes. Simple answer is yes. We've taken an approach of looking at the regulations across the state Medicaids as well as CMS and the qualified health plans within exchanges. Really looked at what's the lowest common denominator as far as frequency of updates of information, what are the key attributes that are required, and built a solution based on that. And then we've layered in the ability to really scale that process. So as we're collecting data, certain states may have variables that aren't common across all the other states or CMS. So we have the ability to scale those scripts to be able to collect that additional information. So it's built on a frequency that will do the required minimum attestation as well as quarterly outreach to providers, and then leveraging the information that we gather across both state and federal requirements. We can handle facilities as well. As Zach had mentioned, we gather information on all the individuals across the U.S. We also gather information on entities, so we can use that entity information to be able to verify, to correct, and to augment information on facilities as well, and then using our multiple channel outreach to reach out to contacts at facilities to be able to additionally verify information if we're not able to verify it from our business level databases.
Great. I'll take the next one. I know we're running out of time here, so I'll take this next one and then we'll decide what to do. So the question is, are there easy avenues to access claims data for non-covered entities? Would these claims still have provider NPIs and address info included? The answer is that it's not necessarily easy to access claims data for any type of entity. It's typically very expensive if you want to lease it, or you have to be providing a very valuable service to the provider or the payer to access the claims data, which is part of what this contributory model addresses. There are some databases that can be had in localized areas. There's no one great solution for across the entire United States, and so what ends up happening is there's a few companies who do various aggregations of large-scale claims databases, but unfortunately it's not easy to do that. As it relates to the the MPIs, the provider MPIs are typically on the claims. Not in every case. We do actually a lot of claim scrubbing as well, and that information is sometimes missing. But more often than not, it's on there, so you can leverage that. And the address info, whether the address is included or just the address affiliated with that MPI number is used, that can usually be found if it's not on the claim itself. But I think the question is good because it highlights that accessing and leveraging claims data is certainly not as easy as I depicted here on these few slides. There's a lot of technical expertise required and just frankly large iron that you need even with cloud-based computing in order to leverage these type of analytics. I think I'm going to turn it over to Claire because we are past our time to wrap this up.
Okay, thank you. And this is Claire Sayer. I'm back on the line here. Well, we'd like to go ahead and take this opportunity to thank our speakers today and our co-sponsor LexisNexis and certainly all of our participants for joining us. We will be sending a follow-up post-event feedback email later on today. Many of you have asked for a copy of the presentation. We will have that available, and I'm going to give you a contact information here. And we'll also include this in the email that we'll be sending out here shortly after today's webinar. But that contact information is Lizzie Feliciano, and her email is leonfeliciano@LexisNexis.com. And again, we'll be including that in the post-event email that we send out. And that's also an opportunity if you have any feedback you wish to share with us or would like to submit additional questions for the speakers, we'll be sure to forward those on to them at that time. If you haven't already done so, we do encourage you to join our LinkedIn group where you can post additional questions or start discussions and suggest topics for future webinars. This now concludes today's webinar.